Doctor, we're going to get started. Just have something. Okay. I may ask. No, I just couldn't hear it all.
Okay. Doc, why don't you come on up here? Might as well get you up here early. Go ahead and make yourself comfortable in the chair.
Thank you.
I'm going to re-swear you because you weren't sworn in front of the jury.
Okay.
Okay?
Yes.
Just give them the appearance that we didn't have the conversation.
I'm at your disposal, sir.
Okay.
Doctor, did you want a bottle of water?
Sure. Thank you. Yeah.
A nice gesture, Mr. Zion. Thank you.
A nice person, Judge.
Thank you.
You are? Okay. Since you're presenting it, make four. One for the court reporter, one for me, one for each side.
Yes, sir. Thank you.
Let's see. A nice shrimp salad.
Yes.
Rye roll.
See, it's not showing up on this for some reason. For some reason, my thing's not up. It's probably not thread.
I think we're going to give a copy of the printed.
Yeah, just so.
May I approach the witness, Judge? I want to hand him his things.
What'd you give him, buddy?
His files, which contain the records.
These are all medical records found within the admitted exhibits.
Yes, there are summaries of them that he has. Do you want me to take those away or just the records?
Or did you show the other side the summaries?
I don't think we have any of the
We
summaries.
never have anything like that.
So, yeah, we'll need copies of all of that, please.
Copies of all, you have copies of everything that's in here.
I mean, of the summaries, if he's going to be using them to
They're
testify.
not summaries. They're
Would you just say they were summaries?
pages.
They're excerpts from the medical
cut out
records.
Pages of the records. They're medical records cut up in pages, basically. That's all they are, but they're all medical records. There's nothing in here that's not a medical record.
Yeah, can we get copies of that, please? I mean, we
How
don't
many
have that.
pages are there?
How many pages? They're all duplicates.
I understand, but you're showing them as a separate exhibit. They're entitled to a copy, even though they may have all the information.
Judge, I got no copies. I don't see anything wrong with copies of stuff there.
But you're showing it as an exhibit, you're not showing it. It's like the whole entourage of exhibits over here. Instead of bringing up all the medical records, you're bringing in specific things that you're showing them. So they have the right to get a copy of what you show.
Okay, let me make sure that he has, I make no false representations. I want to go through everything and make sure there's nothing for medical records. I can have a moment.
Sam, can I borrow your stapler for a second? Well, you've been in possession of it, so.
I got just a moment, Judge.
Sure. Sometimes I just don't understand, Judge Cowcroft.
No, it's okay. Go ahead.
wanted a copy.
Ron already approached.
I already gave him one.
Oh, I'm sorry.
He was the first one I gave.
Okay. Are these ours?
Yes.
Okay.
Taylor. May we approach, I have a question for the court, clarification on something?
Sure.
Judge, I'm ready.
As soon as you want to tell me, say you're ready.
Who prepared these for us?
Remember, I don't sponsor witnesses.
I'm sorry?
I don't sponsor witnesses. Don't ask you to declare I'm an expert because you won't like an explanation.
I won't do that. I heard you the first time.
Yes, we are.
Best buddies. We're best buddies.
We fight like cats and dogs. No, but you don't understand. We have to get along. Because we run the prosecutor's office. We want to. Yes. We love each other. All right.
So you write it since I've already messed it up. All right, I'll use sticky pen.
Be seated. Good morning, ladies and gentlemen of the jury. Good morning. Okay, the coffee smells better than it tastes. Okay, but thank you for the cup this morning. We're going to continue on. I'm sorry about the delay. I seem to be Mr. Popularity today. So it's not any of their fault. Unfortunately, I had other things I had to deal with. So we'll continue on. Doctor, will you please raise your right hand? Do you solemnly swear to tell the truth, the whole truth, nothing but the truth, so help you God?
I do.
Okay, go ahead and have a seat there. Get comfortable. I need you to state your name for the record and spell your name for me.
My name is Joel Zivot. My first name Joel, and the last name Zivot, Z like zebra, I, V like Victor, O-T.
Okay, the brief time I talked to you, you talk louder than that. These people are straining there. Why don't you knock it out? Let's go ahead and state your name again and spell your last name, because that's the tough one.
My first name is Joel, and the last name is Zivot. It's spelled Z like zebra, I, V like Victor, O-T.
Okay, did you guys hear that okay? Okay, Mr. Baez.
Please support. Good morning, ladies and gentlemen.
Good morning.
Good morning, Dr. Zivot.
Good morning.
Okay, well, you introduced yourself to the jury. Let's start with, what is it that are you employed?
Yes, I am.
All right, where are you employed?
I'm employed at Emory University in Atlanta, Georgia.
And what do you do for Emory University?
I'm a physician there. I have two specialties. I'm an anesthesiologist and I'm an intensive care specialist. And I attend in ICUs and teach and work there.
Okay, tell us a little bit, tell us about your educational background. Where did you go to school?
Sure. Well, I went to college and medical school in my hometown, which is Winnipeg, Manitoba, Canada. And I graduated from medical school in 1998. And then after that, I went to Toronto and did a 5-year program to obtain a specialty in anesthesiology with something called the Royal College in Canada. They get to use the word royal all the time. So it was the Royal College, and I became a specialist in anesthesiology from the Royal College, and I graduated there in 1993. From there, I went to the Cleveland Clinic in Cleveland, Ohio, and I did 2 years at the Cleveland Clinic to obtain my specialty in critical care medicine and also in anesthesiology for the American Board of Anesthesiology. So I have a board certification in anesthesiology from the Royal College and also from the American Board of Anesthesiology, and I'm also board certified in critical care medicine from the American Board of Anesthesiology.
Okay, and now, you mentioned that you had trained at the Cleveland Clinic.
Yes, that's correct.
Okay. You do not know, prior to anything involved in this case, you did not know Dr. Husel from the Cleveland Clinic, correct?
That's correct.
But you do have a common training, correct?
Yes, we do.
And what is that?
So Dr. Husel and myself both attended the same fellowship program at the Cleveland Clinic. I was there prior to him by a number of years, and so our paths did not cross. And so we trained in the same institution.
So fair to say your days were much earlier?
Much earlier, yes.
Okay. Now, can you tell us about your clinical experience?
Sure. Well, after I finished at the Cleveland Clinic, I took a position at the University of Michigan
Shouldn't have mentioned that.
I'm sorry. I understand that football rivalries go very deep, so apologies. I have no opinion about that one way or the other. Yes, I confess, I went to the University of Michigan, and I spent 3 years there. I was working as an anesthesiologist and intensive care specialist. At that time there, I was the medical director of the recovery room. I started the fellowship in critical care medicine at the University of Michigan, which is a kind of a complicated process that requires to create a program that would be deemed certifiable according to an organization that does that. I became an expert there in the implantation of heart pumps, mechanical heart pumps, and some expertise in something called extracorporeal membrane oxygenation, ECMO, which has become very commonly used in the time of COVID. I spent 3 years there and then actually was recruited to return to Cleveland. At this time, I went to Case Western because that hospital was starting a heart transplant and lung transplant program. And I had gained some expertise in the care of those patients along with this ECMO technique. And so I went there and spent, I think, 7 years there at Case. And during that time, I was the co-director of the intensive care unit and was involved in clinical practice and anesthesiology and critical care medicine, and divided my time between those things as well as teaching. I ran the program that trained anesthesiologist assistants to work. I was the medical director of that program. I had other subsequent positions there. I taught, I wrote, kind of the normal stuff of academic medicine. After that, I actually was recruited. I went to George Washington University Hospital for 2 years to run their intensive care unit. They were also trying to increase their cardiac surgery program. And after a couple of years there, I actually returned to Canada. And I went to Canada because, primarily, because actually my mother was sick. And I took a position there to go back to be with her, and also, a position that was comported with my expertise. I was the medical director of a cardiac intensive care unit there in a very different system. The Canadian system is very different than the American system, and so I've had the perspective of both systems. I was there for 3 years. During the time that I was there, my mother died, and so the reason to stay there became less important to me, and so I returned to the United States, and that was in 2010. I went to Emory University and took a position in academic anesthesiology and critical care, and I've been at Emory ever since. One other thing I guess that I did in my training while at Emory is I went back to graduate school and obtained a degree, a master's degree in bioethics.
Before you go further, what is bioethics?
Bioethics is the study of ethics as it applies to, healthcare scenarios, to medicine. And so it's a focus of ethical reasoning in the circumstance of things related to the care of people, to healthcare.
And did you utilize your bioethics background in some of the issues that we asked you to look at?
Yes, I would say, the thing about ethics is that people might imagine that there are kinds of things that are ethical, maybe, and kinds of things that are not. I think this is a misconception. I would say that every single thing that a doctor ever does raises an ethical question. And so, should I not? These are all kind of the fundamentals of ethical reasoning. And in the ICU, especially, there are many opportunities to engage, ethical reasoning and adjudication. It comes up all the time.
Okay. And after receiving your degree in bioethics, what other clinical training or clinical experience did you take?
So while I've been at Emory University, I've held also various positions. I've been the director of 2 separate intensive care units. I was also the director of the Critical Care Medicine Fellowship, so taught and trained fellows in a variety of disciplines. I've been on, a number of committees and served, the Emory community. I have adjunct appointments in the School of Liberal Arts, where I've taught a class on law, medicine, bioethics, and policy to undergraduates. And I also had an adjunct appointment in the law school, where I taught a class with a law professor on constitutional law and healthcare. So I've been in all of these places.
While working at the ICU, have you ever done a terminal extubation?
Yes, I have.
How many would you say you've done in the course of your career?
I mean, unfortunately, death is something that is a natural thing, of course, that will happen to every one of us. Every one of us will die. And in the ICU, I would say that on average, if an ICU week, I may have 2 patients that die in a week of work. That's just normal.
Okay, but his question was, how many extubations have you done?
Hundreds, 1,000. It's hard. In over 27 years of career, there's been a lot. So it's that death is a common occurrence in intensive care, and most of the time in intensive care, when a patient dies, they die because a decision is made to withdraw, to stop. It's unusual that patients die in intensive care while being actively resuscitated. It's more common that a decision is made, by the family, that we stop, and we stop.
Okay. Tell us about, have you written any peer-reviewed journals?
Yes.
Okay. How many articles would you say you've written?
Well, gosh, I don't know, many. I mean, on a variety of subjects related to anesthesiology and critical care, and I've also written things called abstracts. Abstracts are kind of short pieces that are submitted to meetings usually and can be then turned into posters or presentations. I mean, I think in my CV, honestly, I can't remember the number, 20, 30, 50, 100. I'm just not actually sure of the number.
Okay, and do you belong to any professional organizations?
Yes, I do.
And what are they?
I'm a member of the American Society of Anesthesiology. I'm a member of the Society of Critical Care Medicine. I'm a member of the American Medical Association. I've been, members of all the state organizations. I'm a member of the Georgia Society of Anesthesiology because I practice in Georgia, and the Georgia Medical Association. I've been members, of the Ohio Society of Anesthesiology, but I'm not actively. I've been a member of the Michigan Society of Anesthesiology, not actively. I've been a member of the Canadian Anesthesiology Society, but not actively.
Tell us why it's important to belong to these organizations.
Well, I think these organizations are places where people of common interest and expertise, of course, gather, to compare and share their experience. These organizations, both of these organizations have journals, and the journals are where information can be exchanged and reviewed. There are meetings that occur, and so there's an opportunity to meet, colleagues face-to-face to discuss and share and exchange. The thing about, the practice of medicine is that one is constantly in training. So although I, quote, graduated, and have been practicing for 27 years, I've never stopped training. There's constantly training and a constant need to be up to date and current, with what's, with the latest things that are happening now. And the association of these organizations is a way that we communicate with each other.
And what are some of the ways that doctors learn after they school, what are some of the things and resources they utilize? How do they continue to develop to become better doctors?
So, I mean, I subscribe to a number of journals, much to the chagrin of my family, which considers it to be somewhat of junk mail. So I get the New England Journal of Medicine every week. I get the Journal of the American Medical Association every week. I get Anesthesiology. I get Critical Care Medicine. And those are the 4 ones that at least I get mailed to my house. And then I have some other review that I'm constantly doing of what's new in critical care. I get email blasts that talk about the things that I've identified, subject matters that then inform me of things that are coming in, that are happening, that are new. And I'm constantly reading. I read while I'm working. So the beauty of the internet now is that when I'm rounding, if a question comes up while I'm rounding, I don't have to stop and look or find a book. It's all available to me. I'm constantly looking up research and to try to apply it to the current situations that I find myself in.
Have you been asked to speak and give lectures, and if so, where?
Yeah, I mean, I've spoken many times in many places around the country and internationally. As an example, I spoke at a meeting in India about these heart pump devices that I had mentioned earlier. I've talked there. I've talked, of course, all across the U.S. and Canada in a number of locations. And I've done some stuff also on being interviewed through some various forms of media on my opinions about various subjects related to my practice.
Do you also have an area of certain areas of research?
So my focus, my focus in the last couple of years has been really, I've shifted a little bit away from the operating room, and now I'm really full-time in intensive care. And so my interests in intensive care have run the gambit of a pretty typical career. I've written in the early parts of my career about infections, something called septic shock, which is something that is pretty commonly written about in intensive care. I've gone through and written and done some work on other kinds of shock. I've written about ECMO several times, and really ventilator management, certain other kinds of conditions that occur in intensive care, a variety of things over my career. I also have, with my interest in bioethics and policy, I do a fair amount of public writing, and public writing, I think, is something kind of new for physicians. We're kind of uncomfortable with that sort of thing. We're much happier when we're among, our people, so to speak. And so crossing over into the public space has been challenging, but I feel it's important and necessary. So I do public writing and public commentary on subjects. I've done a lot of writing in the last couple of years, for example, around COVID. Those of us in intensive care have become very much reluctant experts in the care of COVID patients, and so I've written a lot of things about that. Lately, I've been writing some things about the war in Ukraine with respect to the medical response. I've written about the problems of chemical and biological agents used as weapons. I've written about that.
And that brings me to my next question. Are there times where medicine crosses over into other areas?
I mean, I think that, medicine crosses over. All of us, I think, are concerned naturally about our health. And so it begins with that. So everything, as a doctor, when your friends know that you're a doctor, you get calls all the time. And about things, this hurts.
Lawyers have that problem.
Yeah, I imagine. So
let me ask you this: do you have any experience in some, or do you have any experience in research, in your areas of research, having to do with anything with the criminal justice system?
Well, I've done a lot of work in the area of the death penalty. And the death penalty became an interest of mine a number of years ago, and it had to do actually for me with something that happened about maybe 10 years ago now, where it may have not been that long ago, but there was a drug that I commonly used in anesthesia that everyone used. The drug was called sodium thiopental, and it was a drug that was called an induction agent. So it was given at the beginning of an anesthetic routinely. The funny thing about sodium thiopental is then that when you would inject it into a patient, they would have a funny taste in their mouth that was like garlic sometimes. And so I would tell patients, I'm going to give you an injection and you might taste some pizza. But it was a very kind of commonly used drug that was used all the time. And then it disappeared. It disappeared from the world market kind of suddenly. And I thought, how did that happen? Like, where did it go? I mean, did we forget how to make it? Like, why is it no longer available? And so I began to investigate to try to figure out what happened to sodium thiopental, and it surprisingly led me to the death penalty. And so I learned that certain states that were using the death penalty were executing inmates with something called lethal injection. And lethal injection, sounds like a medical act, but of course it is nothing of the sort. But it uses and kind of impersonates a medical act and takes these things that in my hand are medicine and uses them to execute people. So the story of sodium thiopental was that there was only one manufacturer that was left that was making sodium thiopental. The manufacturer was named Hospira. Hospira is a company that no longer exists, but they were a company that was manufacturing sodium thiopental in Italy. Now, in the
where the garlic came from.
Yes, right. So Italy is a member of the European Union, the EU, and the EU has a rule that there's no execution that's anywhere within the EU, and that no country can make a product within the EU that is used for execution. So it turned out that Hospira was told, can you guarantee that the sodium thiopental that you are making is not going to be used in the U.S. death penalty? And they said, we can't guarantee it. Now, let me be clear, too, that Hospira was not selling it to state corrections, but state corrections were obtaining it. So they couldn't guarantee that it would not be used, so they just decided to stop making it. And that got me interested and began my a long and complex relationship with lethal injection and the death penalty.
So did any of your research involve using medications to actually kill people?
So let's be clear that you can't design an ethical trial that would test the question as to whether or not one drug versus another drug would be better for killing people. There's no way to do that. All you can do, of course, is look to see what has been done by others. But in terms of doing a research, you can investigate it, which is what I did, but I never did a trial, that asked the question. It's not a doctor's place anyway to try to figure out how to kill people. I'm an expert in unkilling, not in killing. So I think that, but others, state authorities who, wanted to execute people would take, again, the things that were normally mine and take them and use them. And so I've had an occasion to examine and review the way executions have been conducted. And it's not easy because states that practice execution, many states also pass what are called secrecy laws. And the secrecy laws ban you from inquiring or getting the details of what's being used in execution. So I could request a protocol for execution and I get a document that's entirely redacted. So every line of it is blacked out.
Let me ask you a question. I think is probably on everyone's mind. Has fentanyl ever been used in any lethal injection, as far as your research?
To my knowledge, fentanyl has never been used in lethal injection.
Okay, and we'll get more into that. Well, actually, while we're on that subject, Have you studied all of the different types of drugs that have been utilized?
Yes, and the drugs have changed over the number of years. Like when sodium thiopental, of course, disappeared, the states couldn't get it either, and so they started to shift into other kinds of drugs that they were able to obtain.
Have you done studies to, or have you researched to see if other opioids have been used in lethal injections?
Yeah. Opioids have been used in other executions. Yes.
Is it common or uncommon?
Not common, but used.
And have they been successful in their use?
Yeah. So it's an interesting question about success. So a term that you may have heard is when an execution is described as botched. Okay, so what is a botched execution? An execution is supposed to, one would imagine that an execution is some sort of event that occurs kind of rapidly, discreetly, and there's no outward suffering of any kind that can be registered. That would be the requirement that an execution needs to be. It's actually based upon the Eighth Amendment, which bans punishment that is felt to be cruel. And I'm not talking about the rightness or wrongness of capital punishment or anything of that nature. I'm just talking about the technical part of how this is supposed to go. So executions with lethal injection have again used other kinds of combinations, and there are two executions that relied basically principally on opioids as the attempt to cause death. Now, in both of those cases, inmates did die, but the description of how they died was felt to have been, quite striking and shocking in how the death in both of those cases was observed to be, quite difficult and seemingly painful.
Did they take a long time?
They took a long time. One execution in Arizona took 2 hours. And the protocol called for the injection of 2 drugs. One was hydromorphone, and the other was midazolam. Hydromorphone is an opioid, like fentanyl. And the dose that they used would have been equivalent to 5,000 micrograms of fentanyl and 50 milligrams of midazolam. They injected that once.
Your Honor, I'm going to object and move to strike that. This isn't his report.
We need to go sidebar on this one. Ladies and gentlemen. Ladies and gentlemen, sorry. Ladies and gentlemen, the jury, disregard the last answer. It dealt with issues of punishment, okay? You're not to consider the concept of punishment for any reason, okay? So I'm striking it all. Mr. Baez.
Dr. Zivot, we've heard comparisons between morphine and fentanyl. Can you tell us, one, are they the same drug?
They're not the same drug, no.
And are they utilized the same?
Both morphine and fentanyl are classified as opioids, so in that way they have that in common, but they're structurally different and have some important different effects.
Okay, and what are the main distinctions between the two?
So morphine is a naturally occurring opioid, and fentanyl is a synthetic opioid. So in a sense, fentanyl is a bit of an improvement over morphine. It's an improvement because it's more potent, so you can give less of it. And also, importantly, you can give less of it for the same effect, but importantly, you can give more of it because when compared to morphine, when morphine is injected, it can cause a kind of an allergy-like reaction. The technical word for it is an anaphylactoid reaction, which means anaphylactic-like. And it will manifest as, say, redness along the pathway of the morphine, and sometimes the allergy-like reaction can be quite severe. And as a consequence, really there's a limit as to how much morphine you can inject at any one time. And so it's not used to give large amounts of opioids like one can safely use with fentanyl.
Okay, so in other words, is it your opinion that you can't give high dose amounts for morphine?
You can't give high amounts of morphine all at once. Now, the reason why we might use morphine at all, you might say, is because it has a longer half-life, it's called. So if I want to give a little bit of morphine for a little bit of pain, I might use an injection of it, and then that could last for maybe a few hours. Where if I gave fentanyl instead, fentanyl has a shorter half-life, and so I would have to give the fentanyl more often. So it's just kind of a convenience factor if the kind of pain control that you need is not extremely severe and you want to be able to inject something not so frequently.
I forgot to mention this or ask you this earlier on, but how did you get involved in this case?
I got involved in this case because a colleague of mine, who was also my former fellowship director, and also the fellowship director of Dr. Husel, we have that in common, Dr. Mark Popovich. He reached out to me and having, knowing me and knowing my background, wondered if I might have something to say about this case and connected me with you to see whether or not I might be able to, give an opinion about the facts of this case.
Okay. And have you agreed to do this case in the work you've done pro bono?
Yes.
So, fair to say that all that is covered is basically your expenses?
Yes.
Okay. And you did not charge for, what records did you review in this case?
All the medical records of all of the 14 cases that are involved here.
And did you also review the medical records of the Tracy Young?
I did as well, yes.
Objection. May we approach Ron?
May I?
Judge, I'm moving on to another
No,
topic.
we need to approach on this, Your Honor.
Yeah. Ladies and gentlemen, this one's on me. Okay?
structured it, the opinions that you were going to render today, are they based on those 14 patients' medical charts?
Yes, they are.
Now, you were discussing the differences between morphine and fentanyl. You recall that?
Yes.
And then I interrupt you with these other questions. Is it?
Now, I want to ask you about, we've had numerous doctors testify that are internal medicine doctors. Can you tell me the differences between training between internal medicine doctors and anesthesiologists?
So, as an anesthesiologist, my focus was the care of patients in what's referred to as the perioperative period. So that would be people who were heading towards surgery. So it would require a knowledge of their medical conditions that could be in any number of things. You know, as an anesthesiologist, I touch on every kind of medical specialty and every kind of medical condition. Then after having made an assessment of their medical state, I would then move to plan an anesthetic that would require it to interact with their medical condition and the surgery that was planned. And then I would care for them afterwards for a period of time in the recovery room. And that's kind of the broad concept of anesthesia. And in many of those areas, internists have some similar overlapping knowledge. What's different about anesthesiology is that not only is it a specialty of a cognitive nature, it's also a technical specialty. And so much of what I do as an anesthesiologist and also as an intensivist are things I do, frankly, with my hands. And so I'm required to do things, procedures, and to handle many of these kinds of medications constantly to draw up these particular kinds of say in this case, fentanyl and morphine into syringes to inject them into patients on a constant, daily basis. So I have a lot of familiarity having seen the way that these drugs work in the body. And in that way, I think that my immediate knowledge and feedback, departs from my internal medicine colleagues who lack that kind of training and lack that kind of immediate practice. And having, again, done this for 27 years, I'm pretty comfortable, with syringes and needles and all of these medications, having injected all of them, into thousands and thousands of patients.
Which of the two specialties would be more familiar with that?
Oh, clearly anesthesiology and anesthesiology, clearly.
Okay.
Yeah.
And but internal medicine still work in the ICU, do they not?
Yeah, internists work in intensive care, and I actually, having been a fellowship director and also a member of a critical care team, I've trained internists who seek to become intensivists. So under my training, I have tried to give them some information that they lack, in their internal medicine training. Critical care has kind of specialties as well. There are subspecialties of the subspecialty, which is critical care medicine. So for me, for example, my subspecialty is care of patients who are undergoing cardiac or vascular or thoracic lung surgery. That's kind of a subspecialty. But I'm also considered to be a general intensivist. So I take my turn attending in a medical intensive care unit as well, and I'm comfortable doing that.
Is there a difference between pain control in the healthy versus pain control in people who are dying?
So there's an important difference in these two cases. So I think that probably all of us have had periods in our life where we've had pain. And pain, can be anything from, minor and annoying to crippling and disabling. And pain can be so severe that people wish for death, when they can't relieve the pain that they have. It's a spectrum. But in the case of where pain control is given to people who are very much alive and intend to remain so, there's a certain kind of pattern of prescribing that's intended to, again, reduce the painful symptoms, and so allows a person to otherwise function in their daily life. When we want pain not to be a barrier, we want it to be able to be something that we can accommodate so we can get on with it. Now, in the circumstance of when someone is dying, near the end of their life, it's a very different kind of project. So, first of all, I guess, the question is dying painful at all? And I think the answer is that yes, dying is presumably very painful. To watch it, having watched it many times, it looks that it can be quite painful for people.
Why?
Because, based upon simple things like simply what they say. People may say, I'm in pain, if they can, or they may, make sounds, of moaning, or in the way that their body moves, and just bringing to bear one's own empathy, the empathy of another person suffering, that we can recognize it, we're tooled for it, we can see it. We can see it even very slightly. It's our common humanity. And so I see it all the time. And, I register it. I'm affected by it. As my job as a physician, I don't want to leave it sitting. I want to seek to relieve the pain and suffering of the patients that I care for.
Can you tell the jury, explain to the jury what titration is, the concept of titration and how it relates to anesthesiologists?
No problem, yeah. I'll tell you actually that when I began anesthesiology, I had trouble spelling that word. So I still have to think twice about it to make sure I'm spelling it correctly. So the idea of titration is to give a quantity sufficient, for the task. It means not to give too little. It means not to give too much. Now, it's difficult to know sometimes how much to give and what are the consequences of giving too little and too much. In the case of when someone is dying, and if one imagines that that's the worst sort of pain, to be facing death, death would be the worst sort of pain. And so it's important, and I think comports with the common practice, to, in that circumstance, use a dose of medication, that would very likely be the sufficient quantity for the task. And so, in a sense, you're titrating, so that you're not giving a tiny quantity, and you're not giving an enormous quantity, but you're giving a goodly quantity that you believe, based upon your experience, that will be sufficient to immediately allay the problem of pain. I don't know. It might be helpful to draw this, or can I draw this, or?
Do I have permission to have the witness sit down so I can?
Yeah, I'm just curious on how you're going to do it.
Right here.
Did I just come down here?
Permission for the witness to step down, Judge?
I need to see what he's drawing. Okay, I can make it
Everyone
work.
else see that?
Down the far end.
You can see that back there? I'll move this stuff back.
Okay, before you start, why don't you explain to Ms. Mick what you're going to put up there?
Your Honor, may we have at least an offer of proof as to what is going to be drawn before something is drawn?
Okay, no. Let's do a sidebar.
Okay.
This is going to be a conversation. Ladies and gentlemen, get busy there. Sorry. Okay, doctor, you may, I'm sorry.
Sorry, I'm sorry.
I was used to your usual timing.
Doctor, you may sit down. Explain to us what you're talking about.
So, fair warning, I'm not a very good drawer. And second of all, I am a teacher. I like to teach, but none of this is going to be on your test. So we're going to start with a very simple kind of drawing, and it goes like this. So this is a graph, okay? And on the bottom here, we're going to call this time, okay? So imagine that this is time 0, and we're just moving along this as time moves forward, okay? On this line, we're going to call this pain. Actually, it's going to be two things. It's going to be pain, first of all, okay? Also, public spelling is a little bit nerve-wracking too, but I'm pretty sure I've not made any spelling mistakes so far. So we're going to call this pain. And we're going to say, we're going to put like a mark here that we're going to call that pain, and we're going to draw a line that represents pain over time. And if you'll notice, the line is sort of going up. Okay, actually, I didn't quite draw it right. The line should kind of be rising. Okay? So imagine that this is the moment where you're now interacting, where you discover that a patient has pain. And this is like the pain line. Okay? Now, what I'm trying to do is I'm trying to give a drug that's going to manage the pain. Okay? And when I inject it, of course, before I inject it, this line is also going to now represent the dose.
Okay, stop. Use a different color for dose, please.
Sorry?
Do you have a different color marker for dose?
Okay.
You have a bunch of, I mean, you picked blue, and that's a Michigan thing, so
Try black for now.
don't try yellow. That'll just set this way
Well,
off.
we're going to say this is now dose, which is in black, okay, dosage. So, at time 0, of course, before I've injected anything, there's no, in this case, fentanyl in the blood, so there'd be 0. Now, in my concept here, in order to get enough fentanyl in here, I've got to get over this pain line to make it work, okay? So if I give a small quantity, as an example, I inject it, and it rises, as I inject it, I leave it, and then eventually it falls. And so it may be something, say, like this, okay? Now you can see here that this was ineffective. So although I've given some pain medication, it wasn't enough. Okay, I didn't get near my pain line, and so the person is still suffering in pain. And so I have to, let's say, okay, I say, fine, all right, I got it. Let me try that again, okay? I'm going to give a second dose now, and maybe I'm going to not wait all the way, okay? I'm not going to wait till it goes to 0. There's still a little bit there. I'm going to try to give a second dose. So I give my second dose now. I'm not starting from 0 now. I'm starting from maybe here. I'm going to give another dose. It's going to look something kind of like, even if I give the same dose, it's going to get a little bit more because there's a little more, it kind of adds. But I'm still below the pain line, okay? And time continues to move forward, and the patient is still in pain and suffering. And so I try it again, and once again, I'm still below the pain line. So even though I redose these things and give more, I never get out to the pain line. And so it's very important that I pick the right quantity to begin with. So also imagine yourself in pain, and I'm saying, okay, hang on, it's going to take me about an hour to get under control of your pain. Like, that is not going to be acceptable to you. You want your pain control to be immediate, because the idea of being in pain and suffering for any length of time is intolerable. And so you want me, your doctor, to fix it right away. So I'm going to give a bigger dose, because what I'm trying to do, instead of this, I'm trying to do this. That's what I want to do. I want to get my dose to be big enough So the first time that I do it, I'm above the pain line. Now, what I didn't show you, didn't draw very well. So again, sorry, this line, imagine that this line is actually going up, okay? So the pain doesn't remain constant, of course. The pain is getting worse as time goes by. So it makes it extremely important, even if that first time I thought I got above the pain line, I still may be short, because the pain continues to worsen as a person maybe bears down on death. And so that's why you need to give this big dose, and that's like titration, okay? So I'm saying, how much is this going to hurt? Well, I think that the pain of dying is extreme, and so in response, I need to give a good and generous quantity, because I really want to get above the pain line, because of course here is death. And that's what I want to do.
And what's the difference between that and giving pain to someone who's healthy and alive, pain meds?
Well, so, there's some similarities here, okay, in that a person that has pain, maybe their pain line, actually, maybe I have the blue again. So we're talking now about pain that maybe is down over here, okay? So it's not the worst pain that you can imagine, it's something less. And so in that case, I can use these lower dosages. It's acceptable, okay, to use this quantity for this kind of pain. But this kind of pain, the pain of dying, is more than this other pain. And so in this case, I need to give more. And in this case, I can get away with giving less.
What is anticipatory analgesia?
So the idea is, like in an operation, for example, a person is going to have a painful procedure. So the thing that I do, and some of you also may have had some experience like this, where you're anticipating that you're going to have pain. And so what we do is we give the pain control before the pain actually is in place. Because it turns out also that if you wait, once the pain is in place, it's harder to get on top of it, okay? So your doctor, for example, maybe you've had a surgical procedure and you've been prescribed some pain control and they tell you to go home. And then you are prescribed this pain control and you're instructed to take it every 8 hours or every 6 hours or every 4 hours. And if they're doing it right, they would say to you, maybe for the first day or two, take it regularly. So don't wait until you're in pain, because if you wait until the pain is bad, you need even more to get on top of it. It's difficult. So we anticipate that it's going to be painful, and we kind of load you up with the pain control that you would need, so when you do have pain, it's much more manageable.
Okay. And what are the consequences if you don't get here during a palliative extubation?
Well, so
Okay,
then...
well, slow down. You need to tie that one in, because he's been talking differently.
Sure. What are the consequences of not reaching the level of pain while doing a palliative extubation?
Well, so the concern...
No, I'm still not there.
Okay. What's the purpose of preemptive analgesia in palliative extubations?
Still don't have your foundation.
Preemptive analgesia, is that an accepted method of giving anesthesia or pain control?
Yes.
Okay. Is it something that's common in the practice of anesthesiologists?
Yes.
And critical care doctors?
Yes.
Is it utilized during palliative extubations?
Yes.
Well, explain to us how that applies in this scenario.
So the problem again is that there's this pain line, which is quite intense and high. And so, like I said to you before, if you were in pain, people naturally would want that period between being in pain and being relieved of pain to be as short as possible. And so I want to be able to make sure that time when we start, and we say, now we're going to do this, we're going to now give you something for pain, people want that to happen as quickly as possible. And so they don't want to wait, because if I'm doing this way, my risk, of course, is that I never get control of your pain, and then you die in pain, which is what we don't want to have happen.
Okay, you might see that.
Put that away. Thank you.
Now I want to talk a little bit about the process of extubation. Is withdrawing, is the process of a palliative extubation painful?
I mean, certainly it can be, yes.
Okay. And when doing preemptive analgesia in a palliative extubation setting, when is it done?
So what happens, so a patient, say, has respiratory difficulty. And so they're attached, through a tube, through a mechanical ventilator that is breathing, helping them breathe. Because without it, the act of breathing is difficult. And everyone knows what it feels like to be short of breath. It's an extremely uncomfortable and arguably terrifying experience in the extreme. And so it's very important to put in place, in this case, fentanyl, to blunt the kind of experience of being short of breath that can immediately occur when the ventilator is removed.
Okay. And what about the clinical picture of the patient? What happens once they're taken off of life support?
Well, I think that what can happen, and it's a hard concept for people, because even the concept of life support, what does it mean? It can be a situation where a person's circulation is very damaged, their ability to circulate their blood, or their lungs are very, very weakened and ineffective, and so they need to be connected to machines with elevated levels of oxygen, or their heart is very, very weakened, or their kidneys have failed. All of these things are common in my practice. And so there can be a place where a person is alive, but completely dependent upon machines and upon medicine. And so sometimes in conversations with families, when we're trying to kind of figure out where we are, I might say, well, this person, is alive, but can never leave this room. So as long as they are in this room with all this equipment, they're alive. But to get out of this room, they cannot. And so if they want to stay in this room connected to these machines, then I guess they can. But most people, when considering that, would say, well, I want to get out of this room. I want to get out of this hospital. I want to get out of this intensive care. I don't want to live like this. And so because they ask for it, these things are removed. And they're removed, and the idea of removing these things is to create a state of naturalness. And so now there is no block, to natural death, which would logically occur after these things are removed. Death is natural.
And how does that relate to comfort care?
So, comfort care, of course, is, when I talk to families, I have a common conversation. And families may say to me, well, actually, let me just back up. That, of course, as a doctor, my contract is with a patient, okay? And the patient is the boss of themselves, and they get to control what they want and what they don't want. Now, what's peculiar about intensive care is that the patient, I may never hear their voice. I may never see them standing upright. I never know them when they're well, and they can never talk to me because they're too sick. And so the entire relationship then dependent upon, what their loved ones, what their proxies are saying. So that's a very complicated position to be as a proxy, And I like to, somewhat cynically say sometimes the easiest pain to bear is someone else's. But for the proxy, it's very difficult because no one wants to think that it was them that, killed their relative or something horrifying like that. And so I instruct people, I say, the way this works is that your mouth opens and their words come out of your mouth. So we're here trying to engage together, try to figure out what this person in the bed would want, okay? So we've decided now that they think that this person in the bed does not want to be in this room, does not want to be on this equipment, does not want to live like this, and they want to be allowed, to have a natural death, if that's what they choose. So in order to do that, of course, again, it requires the removal of these things, and families are frightened. They're frightened, and they say to me, well, what about pain? Like, is it, I'm worried that it will be painful. And so I reassure them, that we will do our very best to try to address the concerns of pain. And I've been in many situations like this where we're standing at the bedside and we've made this decision. And I'll say to them in advance now, if anyone here sees anything that looks like pain, say so, and we will give more, okay? So, I don't like to have to go in and continue to give medications.
Why not?
I think it's distressing and alarming to people to see this. Trying to kind of create something that is, uninterrupted. That there's this kind of opportunity now to be with someone, to be with your loved one in as much as an uninterrupted fashion. So, one simple thing that I, for example, do is, most of you think of a hospital bed that has side rails, okay? They have these side rails, that are put up. So I go into a room when I'm going to do this and I put the side rails down, okay? And maybe their hands of the patients are underneath a blanket, and I take the hands, I take them out from under the blanket, and I say to family, come close now if you want to. You can come right here. You can touch them. You can be with them. And I want to respect that, and I don't want to try to create anything that's too medical looking, where I have to inject stuff. And so, but I tell them, I ask them, repeatedly sometimes, if anyone sees that this is painful, then let me know and we will treat that pain, because we don't want the person to be in pain when they die.
Okay, let me ask you, when creating a dose, well, before I go into that, we've heard a lot about vasopressors.
Yes.
Just briefly tell us what vasopressors are, because
sure.
I don't want to spend too much time.
So, people, might know of something called hypertension or high blood pressure. It's possible that some of you have high blood pressure and you're on a medication. But in the ICU, we tend to see not so much high blood pressure, we see low blood pressure. And low blood pressure is very dangerous if left unchecked. Now, low blood pressure can cause organ damage and it can lead all the way to death. So when people are sick, for a variety of reasons, their blood pressure tends to fall. And so a vasopressor is a drug that kind of pushes the blood pressure back up when injected. And that's why we give it in these sort of cases where circulation is broken or impaired and needs to be kind of propped up with these vasopressor medications, they're called.
And how does that affect the heart?
Well, so, the heart, if the blood pressure is low, it can be because the circulation itself is, well, let me give you an example, maybe a way of thinking about it. So picture a garden hose, okay? So you've got a garden hose, and you've turned the water on, and now you're standing with the garden hose, and water is coming out, okay? It's coming out under a certain force, okay? Now, if you put your finger over the end of the garden hose and partly block it, the intensity of the spray goes up, okay? So in the setting of either infection or other kinds of condition, it's as if you've taken your thumb off the end of the garden hose and now the water is sort of moving in a way that doesn't have a lot of force, okay? And so that can either be a consequence of kind of the garden hose itself, or it can be the tap. the tap is like the heart itself. So sometimes the heart needs to be, the tap has to be turned up, and sometimes the tap is turned down because the heart is not working and dysfunctional.
And how long does it take once you turn off a vasopressor for it to stop working?
So, vasopressors are by design, work very rapidly. And so their offset is equally rapid. So once you turn them off, in a matter of under 2 minutes maybe, the effects are gone.
And
Hold on a second. Hold on. Ladies and gentlemen, we're at about an hour and a half. My desire is to go to 10 till 12 and give you guys an early lunch, but in doing that, does anybody need a break? Y'all good? Make 20 minutes? Okay. We're going my usual timeline. If we're going to go beyond, I just want to make sure they're okay.
I understand.
Go ahead.
So, as it relates to blood pressure, if someone's blood pressure is low, do you take that into consideration for the dose amount?
So the thing about blood pressure is that blood pressure, has kind of a specific purpose here, in that I need to actually have blood pressure to circulate the medicine, okay? So a very kind of particular and graphic example of this is during chest compressions. So when people's heart has stopped, then one of the things to do, or the thing to do, is to, with your own hands, is to push on the chest, okay? And by pushing on the chest, I'm actually creating blood pressure physically with my hands, okay? There's something called open cardiac massage that sometimes is done in my area of cardiac, where I actually open the chest and reach in, and with my hand I'm squeezing the heart directly. But I don't always have that capacity, so in this case I'm just pushing on the chest. So, and when I'm pushing on the chest, I get a blood pressure. And when I get a blood pressure, it means that there's circulation and I can give medications. But if the blood pressure is low, then the medications that I actually give will not circulate. And so I have to give more of them in order to actually get an effect that can be, felt and be effective for the patient.
And once it circulates, does it start taking effect, or does it need to go somewhere else?
Well, it's got to circulate and get into all of the places that it needs to get for it to be effective. So it's not just a moment, it has to kind of, circulate around the body. And I can kind of see this, I can measure the blood pressure and so on, and kind of see the effectiveness of what it is that I'm doing. Or in the case of pain control, I can kind of, gauge, we don't have any pain monitor, okay? There's no monitor I can attach to a patient and it says pain. You have to, this is the only monitor we have for pain is empathy, okay? And we use it to figure it out. So I look at the patient, I look and I see what they look like, and I ask myself, does this feel, do I experience this now as the relief of pain? Is that what I've achieved?
Can you get an accurate reading of a patient's pain or what they're going through at the time of death by looking at medical records?
Oh, no.
So how important is being at bedside?
There's no way to do this except to be at the bedside. You have to be present to know. Because in that description where I said, you could still be wrong. And so you've got to give more. Okay? So you got to be there to know when you give something, is it working? Is it effective? So you got to be right there.
What effect does, let me ask you this before I move on from blood pressure. Is that one of the distinctions between pain control with the dying versus pain control with the living?
Well, I think again that, pain control with the dying, you really only get one chance, don't you? Okay? Once a person is dead, and if you've done a bad job, you don't get a second chance. So in pain control of the living, which is, at least a living person, let's say, a person who's more well and able to tell me, that can be something, there can be some back and forth, where they're telling me, they're saying it's not sufficient. Again, I imagine that some of you, if every of you ever had any painful procedure or something and you're prescribed something, it may not have been sufficient. And so you complain and say, you haven't given me enough, or I need to do this in another sort of way.
And now, I want to ask you about fluid in the lungs. When people have fluid in the lungs, is that something that is taken into consideration for dosing?
I mean, so fluid in the lungs, of course, is a very painful kind of thing. And as an example, like think about a time where you've had a glass of water or something, and by accident, a little bit of it, goes down, quote, the wrong hole. Okay, it goes into your trachea, and it's exceedingly uncomfortable to do that. Even the smallest amount of water, if it hits your vocal cords and into your trachea, you cough, you gasp, your vocal cords can actually spasm and shut tight, and you can't even speak for a moment. It's so painful and difficult an experience. So the airways are basically made for gas, for air only. And any time that there's water or fluid or secretions in there, it's very difficult, very painful. And so you want to make sure that in those circumstances that you're also using, a good amount of fentanyl or pain control to manage the pain, of how difficult it can breathe when you've got fluid in your lungs.
And now, what about fat? Does fentanyl like fat?
So fentanyl is in order for drugs to work, they have to kind of cross this sort of barrier, okay? Like they're in the circulation, and then they're moving along and have to kind of cross from one space to another. In order to do that, they have to pass a membrane, okay? And the membrane is composed of lipid, which is the fancy word for fat, okay? And the easier that there is, and that fentanyl, we call that drug lipophilic, okay? It means fat-loving. It's a funny term. But the idea of a fat-loving drug is that its uptake is more rapid and more quick. But the other problem, and so a drug like morphine, for example, when given, would have a slower uptake because we call that drug lipophobic or hydrophilic. It likes water. It's like the thing about water and oil, think of salad dressing, okay? The way the oil and the vinegar don't mix, okay? So like dissolves like, we say. Fats like fats and water likes water, but you can't mix them very easily. So the more hydrophilic a drug, the more loving it is of water, the slower onset it takes to get going. When a person is themselves obese, so one question is, well, how much do you give someone who's obese? Because there's something called like a ideal body weight or lean body weight, and it's a little bit unclear how much you should give. But generally speaking, when someone is obese, then they get more as opposed to less. In the circumstance of at end of life, where you're trying to make sure that they're getting enough.
Now you mentioned most people. When it comes to giving medication, this may sound like a silly question, but is everybody different? And how does that play into your role as a doctor?
I mean, everybody, of course, is different. Everybody's different. And sometimes the differences in terms of people, you can't tell by looking, okay? So, there you can picture in the bed, some very large, muscular man, whose pain control might be very poor, and he may need, very large quantities. And then picture, someone who's very petite and frail, and their capacity to endure it, might be much more. So this kind of, you can't tell necessarily by age, you can't tell necessarily by weight or gender or any other kind of thing. You've got to kind of look each individual, and you can't tell in advance. It's hard to predict. So I keep an open mind. I'm ready to whatever it is that I need to do, but everybody is a little bit different, and sometimes the differences, again, are not knowable until you kind of start to do things.
Now, we've heard a lot about the combination of benzodiazepines with opioids. Is giving both benzodiazepines and opioids an acceptable practice?
Yes, it is.
Okay. Is it a common practice?
It is a common practice.
Does that include terminal extubation?
Yes, it's a common practice in terminal extubation.
Now, we've heard this phrase called synergy. how does that play into all this?
So the reason, we've talked a lot about fentanyl and drugs like that and how they're specific for pain. Now, what fentanyl does not treat is anxiety, okay, which is a different kind of experience. Now, people can have pain and therefore get anxious about it, or they can have anxiety that is really kind of unrelated to pain. And so if someone, is purely anxious, I would not reach for fentanyl or morphine or any other opioid. And all the fentanyl and morphine in the world would not treat someone's state of anxiety. And by the same token, if someone is having pain, I wouldn't reach for a drug like midazolam, which really is specifically to treat anxiety. It would not matter. So if you picture the idea of dying and the experience, it's reasonable to assume that it produces two experiences: pain, because we've talked about it, and also anxiety, anticipation of death, which can very likely produce anxiety and fear in people. And so I'm trying to treat both of those things. And so that's why, it's not, synergy might mean that like one makes the other more effective. It's not quite right. Is that you're using two drugs that are distinct, but are working together to treat two separate problems.
So does 1 + 1 = 5?
Not that I know of. No, it does not.
Okay,
And
let's put that in context.
Sure.
So
Are you talking mathematically, or are you talking the effect?
The effects. I'm referring to the effects.
So fentanyl does not make midazolam work better. Doesn't make midazolam a more effective anxiolytic, like to reduce anxiety. And midazolam does not make fentanyl a more effective pain control. So they're not synergistic in that way.
Okay. Now, we've heard a lot. We've heard that there is no maximum dose as it relates to opioids and palliative care. Is that correct?
Yes.
Okay. Why?
Because the dose that is, the dose is really the effective dose. That's the dose. And because everyone can be different with how much they need, to use, the concern would be if you set some dose and said, you can't give any more than this, there will be most certainly someone who needed more and didn't get it, okay? And then that person would die in pain. And so we understand that this idea of, where we agree that there should be pain control, it's the practice is not to specify a dose per se, but to say, give what is needed, give what is effective.
And who determines that?
That's, clinical practice. I mean, if you look, for example, the American Medical Association has a statement on end-of-life care. And in their statement, they say, treat to control symptoms. And they don't specify rightly the drug nor the dose, because they understand that it might be different.
Is that on purpose, or is that just because somebody forgot to say there's a high dose limit, or this is the top and no one should go because that would be lethal?
That's based on the experience of doing this work, over, many, many years and many thousands of hours of combined practice of people. Like these things are gathered up by the practice. So, and that's how these positions are communicated.
So, is it based on your training, experience, and research that the reason there's no max dose is because it's patient-specific, or it must be what the doctor believes is appropriate?
I mean, it's obviously patient-specific, and it's also based upon, a doctor's, view as to how much they think a person can need. And, some people, like, I've met, doctors are not all on the same page on this, okay? Like, some doctors, feel that pain, might give small quantities, and others give large quantities. And those that give small quantities might think that whatever, the patient doesn't need it, or the patient can manage without it, or have some other kind of notion about how much pain someone should get. Like I said, the easiest pain to bear is someone else's. So, I, as an anesthesiologist, I'm expert in the relief of pain, okay? And so in that way, I have a strong clinical experience with dosage and pain relief. And it's something, that anesthesiologists are particularly, plugged into and expert in.
I don't understand that there's no max dose, because we hear of people overdosing all the time. Why is,
Sure.
how does that play a role with your opinion?
So, we need to acknowledge that we're living in a strange time with respect to opioids and pain. Ohio has not been spared the problem that is the opioid epidemic. I imagine that people in this jury may have known someone even who have died or who've become injured.
Sustained.
So I'm mindful to our reaction to opioids.
Okay. The objection was sustained. Your question.
Yeah. Tell us more about the issue of why. How is it related between medicine and people overdosing?
Right. So when a person overdoses on opioids, of course, clearly they're not doing that under a doctor's order. They become addicted, and now they're seeking to try to control a very serious addiction, and that's what they're doing, and they make mistakes. When a doctor is taking care of you, of course, a doctor is regulating and titrating and feeding back on what your pain control is. So opioids are, when opioid overdose is self-administered, and it's not under the direction of a doctor, and it's under a very different kind of circumstance. It's a mistake, okay, and that's why that happens.
Is there another reason why people are overdosing on fentanyl?
Well, so it used to be, medicine's relationship with pain control, again, is a complicated one. And there was an edict, okay, that said...
A what?
An edict. Like a declaration, okay, like a pronouncement, okay, that said, henceforth, pain control is a vital sign. So you have to do pain control, okay? Then if you don't, as a doctor, provide pain control, you're not practicing, proper medicine. It was a very big deal, okay? And so everyone, wanted to prescribe pain control. And so opioids were widely prescribed, okay, because people were concerned that if people were walking around with pain, that would be a terrible thing. Now, in our enthusiasm for that, of course, we failed to appreciate, the addictive nature of opioids. And that was a huge, tragic mistake. So then what happened was, okay, oops, we've made a mistake. We know we've addicted all of you. Sorry about that. We're going to now have a new edict. And the edict is, from now on, you can't give anyone with chronic pain more than this quantity. It was just a number. And said, okay, no one can get more than this. Now, the problem with that is that many people were now addicted and required 2 or 3 times that dose. So now the doctor says, I'm not giving you any more, okay? And so what do you do when you're an opioid addicted person? Well, then you try to find it in other places.
Objection. Relevance.
Sustained. Let's tie into something else here.
I think this.
It's
Well,
a
actually,
good time for lunch. I got the idea that's where you were going. So, ladies and gentlemen, we get started back at 1. It gives you an hour and 10 minutes. Have a happy lunch. Remember the admonitions.
All
We'll
right.
see you back at that time. Have a great lunch, guys. Okay. You may be seated. Doctor, you're currently on the stand. You cannot discuss your testimony here today, how you testified, what you testified to. You can answer a factual question, but you cannot, it's not related on how you're testifying or something that you testified to. You understand?
Yes.
You're excused till 1 o'clock. We're trying to move you out of the courtroom so we can talk. Not to be rude or anything. Don't go completely away, Mr. Baez. Anything for the record?
Nothing from us.
Nothing from the state.
Okay. You probably need to capture that too by a shot or something.
Capture. Yes.
Well, I'm just saying.
I'll put a sticker on it.
You put it out fair game. Doesn't mean she can't mess with it.
Right.
But if you want to preserve it, I would say take a picture.
Okay.
Because it's demonstrative in nature. Okay?
Yes, sir.
Miss, anything for the record, Mr. Baez?
No, sir.
Miss Mick?
No, Your Honor.
Okay, 1 o'clock.